Evening,
Right.
everyone.
Yeah. So good evening. No, thank you very much, everyone, for joining us this evening. So we've got another instalment on the UKNG channel, and today we're going to be having a presentation given by Dr. Wen-Xern Chong, who is a consultant at Coventry, and he's kindly going to present giant brain aneurysms and his experience and how to manage them. So thank you very much, Wen. I'll hand over to you, and thanks again.
Perfect. Thanks, Aubrey. So it's Wen-Xern Chong at Coventry Hospital today, 30th October. I'm covering giant brain aneurysms. It's a topic close to my heart because Coventry, we seem to be treating them pretty much every 6 months on the dot. So becoming a bit of a specialist in that area. So I'm going to cover some cases, a little bit of variety, couldn't fit them all in, and cover the different managements and things of the sort. So first off, I've got no disclosures. There's no big aneurysm behind me on this, as much as Coventry deals with giant aneurysms. Now, size of brain aneurysms, you're going to find, first off, the literature varies a lot. This is the more common measurements you're going to find for them, with small, less than 7 millimeters, medium to the 7 and 12, large 12 to 24, giant 25. You'll find some areas in the literature where above 20 millimeters is also considered giant. It does vary, each their own. They are arbitrary measurements, and how you manage them is based on the other features and things you need to take into account, which I'll cover today. So, does it matter being a giant aneurysm? Yes, well, not too many of them. There's roughly about 2 to 5% of your aneurysms you're going to deal with are in the giant category. They do have a higher rupture risk, and we currently use phaser score generally as part of our risk assessments. And again, going back with how the literature looks at giant aneurysms, whether it be greater than 20 millimeters or 25, you're going to quote some very drastic differences in the 5-year rupture risk. As you can see, between the 20 and 25, once it gets to the 25, you're looking at almost telling patients they've got a 50-50 chance this is going to rupture in the next 5 years, compared to a 20, which gives you an idea of the stability. And it doesn't really discriminate too much between anterior and posterior circulation. Obviously, intuitively, we know posterior circulations tend to have a higher rupture risk, even by the phaser score, even with the small aneurysms. We also know they are smaller, thinner arteries and embryologically more of similar to our other spinal arteries of the sort. So it's not too far stretched from the understanding that they're going to have a higher rupture risk. So costs, I know this area probably doesn't get covered, and it's just a weird one that I've kind of strayed to my work, is the medical coding of writing your reports. The trust actually gets reimbursed more if you actually code it higher in the complexity and also the size of the aneurysm. Just a heads up, you do get paid more, both elective and emergency, for that. So please be accurate with your recording of data. That doesn't matter to your unit in the long term. Right. Now, your giant aneurysms, and I'm almost treading over the same ground I'm sure all of you know, there's a difference between saccular and fusiform aneurysms, and it can affect how you manage them. So saccular aneurysms, by definition I've been taught, is they have a single entrance and exit, whereas a fusiform may have a separate entrance and exit and that sort. And we've got examples in this presentation, but I'm sure you've seen in your practice such differences. Sacculars have the beneficial characteristics in our assessment of aneurysm treatment is they're less likely to involve your perforators, having this nice narrow neck, whereas your fusiform involving the parent vessel becomes a lot more trickier to treat because you do worry about occluding more and more branches as you try to plan the ideal treatment for all these, or even not be able to offer suitable treatment as part of that. And now your aneurysms can present in the different ways. Acute hemorrhage, they might present with headaches or diplopia and brainstem issues when they thrombose and cause edema into the adjacent brain, causing TIA-like symptoms. And otherwise, you might find them as an incidental finding, where they may have had imaging for various other reasons of their head, and these aneurysms are discovered. So treatments, there's actually quite a lot of varieties we can involve in these cases, and all of them have their merits and their weaknesses, and they're there to tackle the different diversity of problems that come with these giant aneurysms, because they're not just a brain aneurysm, they're almost like a tumor pressing on the brain. They're there which have a significant amount of thrombus, which can be difficult to tackle in its own right, or might be encapsulated in parts of the skull base as it grows inside your petrous segments, for example. So treatments, as I've got listed here, one is conservative. You might detect these perhaps in patients which are not candidates for treatment, those that are particularly older. I think one of the classic ones which are conservative tend to be giant basilar trunk fusiform aneurysms, where you've got all those brainstem perforators, so you can't cover them by treating the aneurysm in that sense. So that can be quite a difficult topic to discuss with your patients, that it may be futile to offer treatment because the treatment itself can cause major brainstem stroke as a result. If you've got your saccular ones, however, coils can be a very good standard treatment for it. You can occlude the origin and the neck, and therefore you can occlude it just like a small aneurysm, and there's not much difference in terms of that. Otherwise, if the neck gets wider, or it's the morphology or the regional vascular anatomy makes it difficult to get a good packing out that neck, you might lean on some assisted devices, so stent assisted coiling or flow diverter assisted coiling. Otherwise, if you are unable to find such a suitable treatment, or those treatments become riskier, you might consider doing vessel sacrifice and just occlude the parent vessel once you've previously determined, such as a balloon occlusion test, that the remaining intracranial arteries can replace it. Otherwise, you've got some surgical options as well. So let's not forget our neurovascular surgery colleagues. Although they are shrinking in number, there are those with some unique skill sets which are able to help us tackle some of these aneurysms in their own ways. And so you've got the high flow and low flow bypass. The high flows like the ECA to MCA, particularly plug into the distal M1, M2 from the superficial temporal artery branch, as well as clipping and resection. And that can be quite useful because, as much as in the vascular is the high-tech treatments and what we do for most aneurysm treatments, when an aneurysm becomes giant, they can become a tumor, and we don't have the ability to remove that mass off the brain. And there is a role for our neurovascular surgery colleagues in helping us out, perhaps even as part of a combined treatment. So case number one, I wish I could have covered more cases, by the way, but we'll go through these 6 or 7 I've got here. So the first one is your subarachnoid hemorrhage. They've come in this particular case, she arrested outside of hospital. Paramedics got her back, transferred her in. She was still unconscious and intubated, but we got the imaging for the CT head, which can see the intraparenchymal blood surrounding that aneurysm, extending into the ventricles, as well as the CT angiogram on the right, showing the filling of the aneurysm, and noting that at least half of that aneurysm is still thrombosed and not filling. And this was in the ICA termination on the right side with a neck, and therefore was a saccular aneurysm. So first things first, to initially stabilize, there was a hydrocephalus. We put in an EVD and followed that up with aneurysm coiling. So this was the 3D, and that's the angiogram of the images. And again, as you can see, instead of seeing the wall of the aneurysm, all we are seeing is the part that's filling and not thrombosed. We have a whole section that's not demonstrated on there, which is the thrombosed part of the aneurysm. And being saccular, like all our small aneurysms, it's still quite treatable just with our bulk standard coils. They've been on the shelf for many years, invented by Google MA back in the 80s and 90s. I forget the exact year. Someone can chip in if they like about that, and the invention of brain aneurysm coiling. And so for this case, just coiling alone was the main treatment for this, and that stabilized. There was no rebleed. Patient eventually recovered from the hemorrhage and the hydrocephalus, and we even followed that up, and you can see on the 6-month follow-up MRA, the parenchymal damage has caused gliosis in the surrounding areas where there was intraparenchymal blood. There is a bit of a residual neck because we tried to keep the origin of the A1 open intentionally. And the edema, which sometimes can be with thrombosed aneurysms, in this case would have settled down now that there's no more flow into it. Now, a topic that gets bandied about between me and my neurovascular surgeons, maybe occurring in your case too, is that coiling alone does not stop these partially thrombosed aneurysms. They do come back, they recur. I wouldn't agree entirely with that statement. I understand that with coil packing, you still can get filling in between the coils and puts at risk of these recurring in the future, but it requires good coil packing density at the neck to stop that filling, which is where the preference of fluid diversis in treating these partially thrombosed aneurysms has come into. So you can assist that whether you do balloon assisted coiling since it's acute, since you're more cautious on anticoagulation, or you might try stent assisted coiling to get that better packing density. In this case, I packed it just with a single microcatheter, got the right frame, and got the right coils, alternating between the correct filling coils on my shelf. Case 2, slightly different one. This gentleman collapsed. He was a known cardiothoracic patient. He had a porcine aortic valve, and fortunately, because it wasn't a metal one, he wasn't on a DOAC, which we might find more commonly these days, or warfarin. And again, like partially thrombosed, you can see on the CT head, weirdly, this aneurysm is not so visible on the CT head. And the CT angiogram, that's the only part of the aneurysm that's filling, just a tiny dot of it, just at the rough PCOM level. And then we had the MRI workup, which shows this aneurysm with the edema in the temporal lobe. It was figured out from classical history this collapse may have been a seizure-related activity, and we helped reinforce that by the extensive medial temporal lobe edema, as well as the hemosiderin deposition, which shows the age of that thrombus. And you can see the MRA in the bottom left of the screen. There's only a very little part of that aneurysm still filling. So again, like partially thrombosed, you don't necessarily need to fluid divert and things like that. You can just pack them with coils. But I remember from this particular case, he had other cardiovascular problems. Now, this was about 5 years ago at least. And so we tried conservative management because we couldn't find anesthetists to put him to sleep. And unfortunately, more recently, 4 years later, he had a vacant episode, so the anti-epileptics was not controlling it. He had a car crash with retrograde amnesia, and you can see on this scan, again, you've got this little bit of filling, but just comparing with the previous scan, that aneurysm has increased in size. So previously, 4 years ago, you've got this, which is rounder, maybe about 2 centimeters in size, so not giant in terms of one type of measurement, and now is substantially bigger. And you can see the high amount of high T1 signal on that TOF. So you've got the left and the middle images between those 2 4 years period. And that gives you an idea of how much of that is fresher thrombus, because thrombus is not a static thing in these giant aneurysms, or the partially thrombosed aneurysms. Doesn't have to be giant. This is almost like a sand dune. They're shifting sands. The thrombus deposits and then gets dissolved by your body's homeostasis and then gets replaced by fresh thrombus. You'll get different periods when the thrombus is more stable, which is how we initially encountered him. But seeing him again after his car crash 4 years later, you can see there has been fresh thrombus slowly replaced in the meantime, and therefore the change in the T1 shortening. And this time, somehow we managed to find an anesthetist willing to put him to sleep. And in this particular case, because there was no interventional neuroradiologist around, we are short-staffed. The neurovascular surgeons found a very good dissection plane through the sylvian fissure and managed to clip just the neck and left it like that. They did not need to resect the aneurysm sac, although the temptation is there because of its mass effect, because it was adherent and it was invaginating the temporal lobe. So it was not easy to access anyway, and no one was looking to resect some healthy temporal lobe to get to it. But otherwise, the patient has remained stable. Another aneurysm, just to demonstrate how weird and wonderful our partial thrombosis can be. This one's a bit looking like a dented ping pong ball, and no, it is not a ping pong skull fracture in a kid. This is a thrombus inside an aneurysm sac, and like our female patients, that we see some of them form bilateral symmetrical aneurysms, and these can be quite common in the ICA and MCAs. In this case, this is in the ICAs, almost paraophthalmic territory, and the left one is substantially larger than the right. Moving on, this is another patient talking about female patients having bilateral aneurysms. These ones are very important follow-up, and the fact they have bilateral aneurysms should always raise suspicions with yourself if they have a connective tissue disorder. It may not be a formal diagnosis like Ehlers-Danlos syndrome, Louis-Dietz, Marfan's, but they do have the tendency to form bilateral aneurysms and continue growing. And this case kind of covers a little bit of a learning point and how our specialty has changed over the last 2 decades. So this is in 2005 she encountered. I was probably in medical school back then. So my predecessor handled this case, or predecessors handled this case. As you can see on the MRA, you've got the left ICA aneurysm. This was in the cavernous section. It caused a retroorbital headache and intermittent diplopia, which is how it's detected and scanned. And you can see a little bit on the right side is slightly ectatic, but a bit of a borderline whether you want to call that aneurysmal fusiform dilatation or not. Now, she was not treated then. Keep in mind, this is before flow diverters even existed in the world by a good decade, or almost a decade. And so they tried to follow up and see if they could avoid it because the symptoms had resolved and the patient wasn't experiencing treatment, experiencing any further symptoms, and therefore wasn't a strong case for treatment given the risks of trying to do coiling or stent coiling for her at the time. So this is a follow-up MRA 16 months later, and as you can see, there is substantial increase in the size. I will flip back and forth between the slides for you to see again. Before, after. And so in that 1.5 year period, there's been a significant increase in size. And again, on the right side, the contralateral side, you can see that side also growing at that time as well. Now, Coventry didn't have an interventional neuroradiologist at the hospital at this time, so they were referred elsewhere, I believe to my colleagues in Newcastle back in 2005. Which provided the treatment, which they did a parent vessel sacrifice, which is an appropriate treatment at the time. However, as you saw the right-sided aneurysm already starting to grow, and these, while not having a formal diagnosis of connective tissue disorder, there's a preponderance for the flow stress that in the ICA to encourage aneurysms to grow. And in this case, the parent vessel sacrifice accelerated the growth of the contralateral aneurysm. And as you can see, the 3D on the right side in the years later, although this is a good decade later in 2017, she got lost to follow-up because the parent vessel sacrifice was termed done and dusted, and this patient was discharged until they started experiencing the same retroorbital headache but with the opposite side. And now you've got a bit of a challenge, is flow divert is now our present option. So you could flow divert this to preserve the vessel, since you are not going to get much success doing a bilateral ICA parent vessel sacrifice. But if you look at the distal ICA segment, unfortunately with it has become ectatic. And measuring the landing zone of that distal ICA, you're needing a stent with an 8.2 millimeter diameter, which unfortunately on the market, your options are extremely limited to nothing at the moment. Someone can correct me, but I think the Del Riva goes up to 6.5.
I think there's a 7 as well, but
7.
nothing up to 8.2.
No. So there wasn't a flow diverter option for this as well. And also trying to show you on that 3D, with that additional flow stress, the posterior circulation has had to contribute also to that circovolus since the vessel sacrifice, and that basilar trunk is also starting to become ectatic too. And so with that conundrum, the neurosurgeons did not want to touch this because they felt they had no great options to reconstruct that vessel. I know when they have some difficult larger aneurysms, one of their techniques is to temporary clip proximally to occlude the artery, pop the aneurysm sac, clip to reconstruct the artery again, and then release the temporary clip. But given that the other side had been sacrificed, that wouldn't have been very possible for maintaining brain perfusion in that period. So that was not offered as well. And it has continued to progress. We have scans even recently as this year, as this patient's diplopia is not a permanent feature, but still intermittent, but getting worse, but lacking the endovascular options as well as surgical options. We have seen this aneurysm grow further, and as you can also see in these CTAs, the basilar artery is growing further too, and we have a fusiform aneurysm of the basilar artery. And this is a bit of a reflection point of how our specialty has changed. If we had encountered this patient just a decade later, from 2005 showing up with that aneurysm, now it's a nothing type case. We put a flow diverter, done and dusted. If the other side grows, we'll also flow divert that at a separate date. And that would have been a great option then, but it was not available. And we can prevent that as much as we like parent vessel sacrifice as an alternative tool. We have to be wary in those which sacrificing one artery increases the flow stresses in the remaining vessels. And if they've got many more years of life, as we're keeping people living longer and longer, you're going to have the other vessels put to the test and grow further and further. And you can lose those options very quickly of what you can do endovascularly or neurosurgically. This patient I remember quite well. This was one of my earlier cases when I started as a consultant. I think I wasn't even a consultant a year when this case landed on my door. This 47-year-old alcoholic with not the most sensible of mental statuses had become more acutely unwell, according to his carers. He mentioned he was seeing his mother and speaking for collateral history, I believe, to his brother at the time. Their mother passed away about 6 years prior to his presentation. So, but the patient was adamant he was seeing his mother at home and talking to her. So that's when they sensed something was wrong and they got him a scan. Other than that, they then started noticing a bit more subtle is also one side facial expression was a little bit on the weaker end. So a bit of facial drooping on that side. And as you can see, there's this CT scan there. And this was picked up by one of our radiology registrars overnight. And I believe because of our lovely short staff of neuroradiologists, I think it was an MSK consultant that was asked to first check the scan for the registrar and reported it as a possible tumor, but actually, to applaud them, they still put aneurysm as their differential. And lo and behold, as this presentation would suggest, this is a giant aneurysm. And you can see the CT angiogram on the right side. Again, very little filling. A lot of that is thrombosed. And you can see on the non-contrast CT head, it's been there some time with calcification starting to develop. And also looking at CT head is the fact that the basal ganglia are losing their density. This thrombosis is slowly spreading edema through the basal ganglia and midbrain, which the timing could not have been better because in the first few days of his admission, he already was starting to decrease in his conscious level because of the midbrain edema. Now, how did we tackle this case? We had two problems. One was this is acting like a tumor. This was compressing the third ventricle and the aqueduct. So this patient was going to decompensate very slowly in this case, since he's had the center for a while, into obstructive hydrocephalus. And then how we're going to occlude that aneurysm. Now, finding a neurosurgeon to do the EVD or VP shunt, managed to do that, but there's no good resection mud and plane to approach anything in the third ventricle, including in this case it's a basilar tip aneurysm. So this is where we worked in tandem. The neurosurgeons, we organized them to do a VP shunt first, and because it was a basilar tip and was wide enough that we needed to use a stent to get good coil packing, we had to wait for them to recover from the surgery before we started to do antiplatelets for, in this case, a flow diverter assisted coiling. So this is the MRI, and by then the patient was already starting to deteriorate, and you can see he was already moving in the scanner. And you can see the edema developing in the basal ganglia around the internal capsules, lentiform nuclei, midbrain, thalami. This was just shy of 5 centimeters, and you can see on the T1 the different signal changes with the different age of thrombi. This was the VP shunt put in by our neurosurgeons. Now they had to do this a little bit endoscopically and in a less traditional method of a horizontal approach to the ventricles because this aneurysm was acting as a tumor blocking the foramen of Monroe. So putting a VP EVD would not have been satisfactory because we had no solutions to remove the mass effect of the aneurysm, which was with that thrombosis potentially adherent to the midbrain and third ventricle wall. And putting a EVD in one ventricle would not also drain both because of the obstruction foramen Monroe. So we picked a more permanent option with the VP shunt and did it endoscopically to try and hit both frontal horns, and also out of their curiosity they wanted to see the aneurysm for themselves, which unfortunately they could not get the images saved from their microscope and endoscopes across to the surgical notes, which is a shame I don't have that for you today, but they could see in the foramen Monroe this big yellow fleshy mass, and it had a life of its own. It actually had vessels on its wall as well. The aneurysm was more and more like a tumor to them in the direct visualization of it. And then they wished me luck. Gave it a few days before they told me, yep, I can start the antiplatelets, and we got him in. And this was the initial angiograms. We did a full angiogram anterior and posterior circulation. So dominant left vertebral artery, you can see the part of the aneurysm that's filling. And we did angiograms of both ICAs because we wanted to see which side we had to put the stent in. And as you can see, the left ICA has a substantial PCOM artery, a fetal PCOM in this particular case, which meant if we occluded and preferentially deployed the stent in the right side, it should not affect the PCA territory. And that's what we did. We aggressively packed that aneurysm right down to the neck, including to the P1 origin, knowing that that P1 will be retrograde filled from that PCOM. And so here are the images from the case. We've got the photoverter stent being deployed, and we looped the microcatheter at the fundus of the filling part. It was still surrounded by a thrombus. And by looping it, it gave us actually a better coiling packing. Because if you have your microcatheter pointing into the aneurysm straight on, your forward tension would pack it denser distally. But because we had it looped and facing downwards, when we sized these coils and inserted them, they packed the neck denser in this particular case and managed to pack it all the way to the left P1 origin. As you can see with the image in the center showing the left P1 no longer fills via the basilar, and the right image showing again the final image with the coil packing and the density you can see we achieved with that, which I think was 11 coils, if I'm remembering this case correctly. 11 coils and a photoverter stent. And the patient still stayed in ICU because they were still unconscious from that brainstem edema. It took 3 weeks for his edema to slowly settle down, even with steroid cover. At our center, we use dexamethasone to keep familiarity, since we use that for tumors in the neuro-oncology setting. And then he woke up. We transferred him to the ward, and he got discharged from hospital a week after that. No issues. And this is the 6-month follow-up scan, before and after. So I've got T2 images before and after on the left, and T1 images before and after on the right. And you can see sealing the entrance is how much the thrombosis shrinks the aneurysm. You can see on the T2 how that dark hemosiderin, some of that's been removed. The mass has decreased in size. The edema also of the surrounding midbrain and basal ganglia have decreased in size. And on the T1, although he's moved a bit in the first scan, you can see that initial T1 shortening and layering at the anterior part of the aneurysm. Now all of that aneurysm is slowly remodeling, so to speak, as the thrombus is being freshly eaten away, shrunk, and removed, which is also reflecting the fact that hemosiderin has reduced as well in a follow-up. So he remained well, actually, for good. He nearly made it to 2 years, but unfortunately, while the aneurysm treatment was successful in all technical aspects, including the VP shunt, he had complications with a GI bleed even when he was off his dual antiplatelets because of his alcoholism, and he may have, I didn't look into it in detail, he may have died from a variceal bleed roughly about 18-19 months post-treatment, which is a shame given the technical success of the aneurysm, but such is life. Now I've got another case here. Looks like a giant aneurysm again, right? Big sac on the T2 and the T1. You can see the layering on the T1, the different age thrombi and the hemosiderin layering. You can see it on the sagittal T2 with the obstructive hydrocephalus, including the fourth ventricle and the brainstem compression, particularly on the medulla oblongata, which is, this is what's all on the presentation. But as you can see from this angiogram, this turned out to be a varix from a fistula. And you can see on these right vertebral artery projections although subtle, because of all that thrombosis, there is a fistula from one of the branches of the vertebral artery. And this was removed by surgical resection, which unfortunately our neurovascular surgeons were all simultaneously on leave at the time. So we got this resected, I believe, in Oxford, which took it and pretty much removed it as a mass effect. So as for them, it's like, well, they did a advanced Chiari decompression, removed the suboccipital bone, remove the venous sac, as well as identify all the different feeders and veins around it. So not every giant aneurysm is an arterial aneurysm. This is in case your varix, and we've had 2 other cases where they're presented with quite large varices, some of which were thrombosed, some of which were still patent. And there is significant roles in the surgery side to resect the mass effect of them, but can be a joint procedure because the surgeons may not be able to access the dural feeders, which are probably the more common feeders in a lot of cases, which we have better access in disconnecting before removal of the mass effect of it through surgery. This is another case, 66-year-old female. Again, this one's a brainstem compression. You can see the edema in the middle image on the sagittal T2 with the pontine compression and the pontine edema. I've got 2 sagittal T2s because it doesn't completely cover the entire aneurysm, and you've got almost like the aneurysm at the neck is your parent, and the daughter is far larger in this case and is causing the vast majority of the symptomology. And you can see on the CT scan the peripheral calcification, the different densities, as well as the hemosiderin showing the different age of the thrombi. We further had other MR images, and you can see we've done flare, T1 time of flight, and T1 with contrast. And you can see with the flare, the highest signal and age in some of the thrombi. The T1, you can see that actually very little of that aneurysm is filling. And in T1, because with contrast, given a bit more time with that contrast, you can see that blood can penetrate the thrombus, just albeit a little bit in weird patterns, in this case quite curvilinear, which your angiograms will never show to that degree. Now, what's unique about this anatomy, I think I have to show it on the DSA, is it was a vertebral basilar fenestrated giant aneurysm. It was a bit of a mouthful for the report and discharge letter. And so, as you can see from the 3D map, what our plan was is, given the wide neck and given there wasn't a very dominant limb, we did kissing flow diverters and then coiled that neck with high density coil packing to seal off that aneurysm. And you can see the angiogram images, the filling from the right vertebral artery. Now, how we did this case, I still remember, is you can see on the 3D, the left flow diverter planning is a bit more of a acute angle, which is why the 3D prediction on the software wasn't able to try and match it very well. So we first went up the left vertebral artery, spent our time carefully navigating into that left limb of the fenestration, and we deployed that flow diverter first, and that gave us protection from the neck of the aneurysm into that area. And then we went up the right side and double catheter, one to deploy the flow diverter to jail the coiling catheter. So we had the right kissing stent then deployed second, followed by the coils. And you can see here some of the fluoro images during the case, the deployment of the kissing stents and the coil packing, and the final angiogram showing no filling of that aneurysm and no change, in fact, probably better flow distally in the contrast And we follow this up. Again, you've got the top images is when she presented. You've got axial images of flare in T1, time of flight, which shows the mass effect indenting that pons with the edema, including distorting that fourth ventricle. And you can see again 6-month follow-up how much that mass effect has shrunk. The edema settled down, and yeah, we didn't need to resect the tumor mass effect of it. It sorted itself out. Although we already had some prediction this was going to resolve itself without issue, because even her symptoms were quite mild on presentation. And even when we treated it after a week, nearly a week of monitoring on the ward, the thrombosis did not progress in terms of causing any more brainstem symptomology. And she discharged, I think, at day 5 or 6 without a single headache issue. So it's a very good result in this case. One of the options you can do, as mentioned, photoverters with coils. This one's a bit of an awkward one. See how many people remember, but this is a 44-year-old. He presented with severe headache and vomiting. He has Klippel-Trenaunay syndrome, which I put an image in the right just to remind everyone this lovely rare syndrome, so they can get a limb hypertrophy, just one limb, with port wine staining, and they can be put at high risk of DVTs in that affected leg as well. But in this case, unrelated to his Klippel-Trenaunay was his severe headache and vomiting. And as you can see here, and in the theme of our discussions, we are covering giant aneurysms. We've got different age and density thrombus in the non-contrast CT head. And you can see on the contrast, there is very little filling of that aneurysm. In fact, it looks like just the vertebral artery glancing past it, like an incidental tumor where we see with meningiomas at the clivus wrapping around it, except this isn't touching the clivus at all. But further to this, looking at the next slide, is sagittal imaging. Again, with the T2 and the T1, we can see it indenting the brainstem with the edema. But not only that, he's got now an acquired Chiari malformation as a result of this. And we examined him on the ward and asked him to Valsalva, and he was able to reproduce his headache symptoms, which was a horrible thing for him, and asked us not to do it again. And so MDTs, 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 these are complicated. We're addressing both the tumoral mass effect of these aneurysms, as well as how to stop these from its bleeding risk, since they're in the 40-50% 5-year rupture risk as well. And so in this particular patient, the immediate threat was actually his severe headache and vomiting from the Chiari. And so what we did was a Chiari decompression first. Because the plan for the aneurysm, as I discussed with them, was going to be a flow diverter, given the neck is pretty much that distal vertebral artery, as you can see on the CT angiogram. There is no narrow neck coiling option, and therefore dual antiplatelets were required. So we did the Chiari first, and as you can see here, now with the Chiari, they also put an EVD with the operation, because the swelling of the operative of the operation site post-op led to a supratentorial hydrocephalus. And then once the hydrocephalus was settled, and that was with clamping the drain, then we removed the EVD. And this is the recovery, as you can see, the burr hole, but no EVD in his follow-up. This was when the neurosurgeons show him clinic, like, fine, you've survived your Chiari, now I'm handing you over to Dr. Chong, and he's going to sort out your aneurysm. And that's what we did. Now, this was the 3D. And as you can see, it was not a pretty one. And unfortunately, on that 3D and on the angiogram, the ICA comes out of the ICA pike. The ICA comes out of it, the aneurysm sac, which made planning for how a photoverter would oppose the walls, especially since, again, looking at that 3D or in the angiogram, the artery wasn't a consistent caliber. In fact, it gets wider and wider when it gets closer to the aneurysm, and it gets smaller and smaller as it goes away from it, even distally at the basilar. So finding an appropriate sized photoverter and managing the risk of fish mouthing because of the change in diameter was going to be a tricky one. So we, in this case, opted to avoid coiling this one and just go for pure photoverter, and then slowly wean the steroids over a longer period of time. We tend to wean the steroids over a short period for the ones we're expecting thrombose in a quick fashion, usually within a month. But for this, we expected to try and wean this over several months, which the patient understood and was happy with. So what we did was we telescoped 2 photoverter stents to cover the different calibers and also cover the length, given that a large portion of that vertebral and proximal basilar artery was part of this fusiform aneurysm sac. And as you can see, it did already cause contrast stagnation bit by bit. And you can see on the lateral on the right side, the layering of contrast, which comes with it, as during the case, the contrast itself layers, which kind of represents of how the thrombosis is going to occur bit by bit. And surprisingly, he didn't have that much headaches after, given how much of the sac we left. But nonetheless, we still were cautious. We kept him on the steroids and omeprazole PPI cover in this case. And unfortunately, with this case, he had a significant GI bleed, and someone had stopped his antiplatelets to treat the GI bleed. And so while he was doing well and recovering in a month after, as we have the risks of GI bleed with antiplatelets, stopping them in this case thrombosed the photoverter stent and the aneurysm, and he had a massive basilar infarct in this case. Not a great complication, and one of the risks, the fact we deal with anticoagulation, as much as we've made advances in trying to optimize our antiplatelet therapy for our stent cases, there's other complications outside of the neuro setting, which is the risk of epistaxis and GI bleeds, which goes up. Yeah, bit of a learning point on that. Coming up to the end, I know this has gone longer than the LK time, but I just really wanted to squeeze in this monster of a case. This is the last slide, I promise. A giant aneurysm that we had, and it was so giant you can see the contrast just didn't want to leave and feed the brain after that. You can see the original angiogram as we inject, and pretty much all the blood off the ophthalmic artery just sits in the aneurysm sac, and very little went up. And now he passed his balloon occlusion test, and we potentially looked at a parent vessel sacrifice. But one problem we had was the angiogram couldn't confidently identify where the anterior choroidal artery was in all of that. However, the neurosurgeons would have that option. So we sent him to, in this case, Oxford, to do a high flow bypass, which you can see the image in the bottom left. And then they were able to temporarily clip the aneurysm, identify the anterior choroidal artery, and then decompress and clip most of the aneurysm, but spare a little bit of the neck that fed the anterior choroidal artery. And therefore, this patient was spared an anterior choroidal artery infarct through this combined effort between INRs and neurosurgery. Right, this comes to the end of my talk. There were so many other cases I could have included in here. I've got ACOM, giant aneurysms, I've had other basilar aneurysms have an ICA aneurysm, which is slowly eating into the petrous like a mass. But alas, we have gone well beyond our allocated time. So thank you very much, guys. I'm going to hand this back to Aubrey, and hopefully not too many questions.
Wen, that was fantastic. Thank you very much. That's a brilliant talk and some fascinating cases. And I think you've highlighted some really very important points. Dealing with giant aneurysms is not easy. And as you said, there's so many different approaches that you can take for these. And I think, as you said, it's really important that you have a full-on MDT discussion, discuss closely with your colleagues, and also make the patient fully aware of what's going on and how you're going to approach it. So, Gaston, you're here. Did you have any questions at all?
Thank you very much. I think that was very comprehensive. Very good. Just regarding antiplatelet therapy for those who get stented, what's your protocol? I've noticed there's a significant variation nationally in terms of loading and then maintenance.
Right. So our current protocol at Coventry is dual antiplatelets, where we use aspirin and prasugrel. It's quite fortunate we actually have access to prasugrel because the cardiologists here like to use it as well. So it wasn't an issue convincing pharmacy to stock it. It was, yeah, well, some other people have it, so let's just add stock to you. But I know some other centers might have issues, and ticagrelor is also an alternative. Now, the loading dose and maintenance dose. So in the elective setting, where you have time to work up, the loading dose, we can start with 5 days of 75 milligrams of aspirin. And that's quite easy to get over the counter, or even a GP prescription. The prasugrel is a bit of a harder ask, and you'll get a lot of resistance from GPs because it won't be on their local formulary. It's a specialist prescription, and you're asking them to start it rather than yourself to start it and then to follow it up with repeat prescriptions. So that can be a bit of a contentious point logistically to do. What we've figured out is the pharmacology of prasugrel is brilliant in that it takes 2 hours to peak. And that's a very useful tool about it, because that also is something we can use for the acute setting. But in this particular case, even my elective patients, I can give prasugrel on the morning of the procedure and add in the time to have them swallow the tablets right during the consent process. Hi, you're here for your aneurysm case. Let's go through the risks. Happy? Cool. I've got this little pot for you here. Swallow the tablets. Lovely. Awesome. So then I've got the anesthetist to see them, collection, general anesthetic, set up equipment, groin or wrist puncture, angiogram. And by the time we get to that stent deployment period, that's 2 hours since they have had the tablets, and it's working perfectly. I've not had any issues with that. In the acute setting, you can do that as well. So you can start 300 milligrams of aspirin and prasugrel also loading dose on the same day. The prasugrel loading dose is 60 milligrams if you're trying to load it that quickly. If you're feeling a bit less ambitious about it, you can do 30 milligrams the day before and more gently load it, or consider 30 milligrams in those in perhaps smaller body sizes, because that's how it can be with dose and their body weight. So maintenance doses, 10 milligrams is what the BNF formulary says once a day, but we've managed fine also with 5 milligrams once a day. How we can use this a bit more creatively is, I've got a patient coming up who's allergic to aspirin. So what we have done for her is we are preloading her as a 5-day loading, in this case of the prasugrel. So we're doing 10 milligrams once a day, slowly building up to that loading dose for the day of the procedure as a single antiplatelet. We will continue that for 6 months. And then given the similar mechanism of action, we will just switch the next day to 75 milligrams of clopidogrel for the following 6 months, still doing our close equivalent to a dual antiplatelets for 12 months approach and stepping it down after 6 months. I hope that's answered your question.
Yes, very comprehensively. Thanks. Thank you.
No, that's brilliant, Wen. I had a quick look as well. The Derivos now go up to 8 millimeters, so they can go as far as 8 millimeter by 5 millimeters in their legs. So yeah, there are bigger stents now available, but there never used to be at that size previously. I think giant aneurysms are fascinating, and I know you were talking about the layering of the thrombus that can occur. And people have actually done pathological studies on giant aneurysms, and what they've found is that that you get vasa vasorum that come and arise from the neck of the parent vessel and actually go and track up around the wall of the aneurysm. And when they've actually dissected down into the aneurysms themselves, you can actually see that they're very small little vessels that go into the thrombus component of the aneurysm. And part of the reason why they regrow and they grow even despite there being minimal filling even at the neck is that these vessels, they bleed into the thrombus, and then you get that layering of the thrombus within the aneurysm, and it causes them to grow. And even though you might luminally block off the vessel, sometimes these aneurysms can still bleed from the wall of the aneurysm, even though they're not filling luminally. So they are very difficult. They are very difficult to treat, but I think that's why sometimes flow diverters from the endovascular point of view work very well, because I think that does interfere with those vasa vasorum filling as well. And I think everything that you said as well, in terms of tight packing and everything with the coiling is so important. And thank you very much, Wen, for showing all your cases and making all those points. Thanks very much, everyone. So I think, Wen, is there anything else you'd like to add or anything from your side?
Nothing in regards to giant aneurysms, I'm afraid. I covered as many cases as I could. Try not to spend a whole day talking about it because we've got many other cases.
Yeah, no, it's, they're fantastic cases. They're great. Thank you. Excellent. So I'll bring the session to a close, and we will. There's UKNG coming up in November. I hope you guys can all come to the training session if you're coming. There's a full lineup set up ready for you in Oxford. So thank you very much, everyone, and have a nice evening.
Thanks. Bye-bye.
Thank you. Bye-bye.
Bye-bye.